So during the exam, the examiner will behave in a certain way and they are going to a script. So I'm going to enlighten you about that. This information is usually not available to us through the test centres, but as is mentioned previously, or if you're unaware, we do work with examiners that have previously worked at the test centres, and obviously they no longer work there because that would be a conflict of interest working with training companies like us. But we are the only training company in the UK that has access to inside information from ex-examiners. I'm just going to explain to you from an insider's point of view what happens in the exam. So having worked with some examiners now who are working with My Nurse's Life, or ex-examiners, so these are people who've left to work elsewhere and they know exactly what goes on and have been able to help us to deeply understand what happens in the exam and share that with you. This oxygen therapy station, we know that the examiner is going to say to you, this is the oxygen therapy exam, so you'll know that's what you're doing, that's what the station you're in. The examiner has a script and they're told they're not allowed to interrupt you during the exam, but if necessary, they can give you prompts, as in they can ask trigger questions from the criteria, and we do hope, you know, that you are listening for these prompts. So if the examiner says something like, how would you know that's the correct flow rate? It's because you haven't opened the oxygen valve completely on the oxygen point to be able to let the mask fill up and 15 litres of oxygen flow through. So we're able to pick up on these cues from the examiner, and please do listen and look. Sometimes examiners are kind, and we know this from inside information. Sometimes they can give you eye contact. Maybe they'll look at your chart and they'll be sort of giving you a clue that you didn't do one of the rights of medication. You haven't checked the chart properly. Maybe you didn't sign it or date it. So we do know that examiners will sometimes help you, but they can only prompt you once, as in, have you completed all the checks they're allowed to say? Have you completed all the checks and demonstrated? So they might ask you to explain that in a verbalised way. So if you're seeing, here's a chart, here's a medication chart, and if you are seen to just be reading it without verbalising it, so you're pointing, so you're obviously reading it, but you're not saying it, they're allowed to prompt you once, but they're not allowed to keep prompting you. So in this chart, I'm going to say the patient's name, Jordan Singh. I've already checked the other part of the chart. I assume I've already checked that part, and I could write my name in as a person who's administering medication. And I've also got to identify that the patient doesn't have any allergies, although this would have already been established in the scenario that there's no contraindications and there's no allergies. Contraindications could only really possibly be that the patient is a hypercapnic retainer, which means they retain carbon dioxide because of a cardiac or predisposing respiratory condition. They're in cardiac respiratory failure normally. So if the patient isn't a CO2 retainer, it is tick, that part of the chart. The doctor should have put the target sats with a cross next to it. Target O2 saturations 94 to 98, and that's what we'd expect in most people and children. We don't really expect them to have target sats of 98 to 92 unless they have prior issues. So the doctor would have already indicated that. And then we need to be seen to mention the device, which is a reservoir mask, and that has the abbreviation of RM. It's here. You can see reservoir mask, RM, and then doctor's signature. We have to point that out. Doctor's signed it and printed the name. And start date today. Stop date is actually continuous because we don't know yet whether the patient will respond immediately to the oxygen, so they haven't put a stop date, and so that isn't a consideration for you if that is not got a stop date. The start date it'll have on it. So that's the rights of medication. As long as you've done that, that's actually critical. So you must be seen to do that. The examiner will also may give you a prompt to another critical, which is checking the patient's ID. So when we're checking the patient's ID, we're using this chart and we're going to be asking them what their name and date of birth are. Now, this child is born in 2017, which makes them 7. A 7-year-old child may not be confident enough to say to you as an adult that they don't know their date of birth, or they might not even know it. So they probably know their first and last name if you ask them. But we do obviously deal with different sorts of children. Some are terribly shy and some may have some learning disability. So in the OSCE, they don't have a learning disability, but we may have to ask the parent. The child might not be either capable or comfortable giving you their name and date of birth, so we're going to ask the parent. And also it's a way of us including the parent, isn't it, in the assessment, so we can ask is for their name and date of birth. Please don't tell the patient and the carer or parent, or don't tell an adult if it's the adult that you're assessing what their name and date of birth is. Ask them to tell you, and then do check it on the chart if they're wearing a wristband. So this patient has a wristband here, and I'm just going to check the patient's wristband while I'm checking the chart, and I'm going to be seeing, he's told me he's Jordan Singh. It's the 1st of the 1st, 2017. The mother's confirmed with me, so they wouldn't know their hospital numbers, so there's not really much point in asking them. But we've got Jordan Singh, 1st of the 1st, 2017, hospital number 0004321. Jordan Singh, 1st of the 1st, 2027, hospital number 0004321. So we checked it, and that's correct. You are meant to say, have you got any allergies? Even though it says in the station that there's no contraindications, no allergies. Have you got any allergies? No. Okay? And that's what it says on the chart. So that's all fine. So you need to go through this station, and you need to be able to choose the right device. So I've just got 2 masks here to show you. This is obviously for children's, because they're small masks, as you can see. With the device, they can give you more than one device, so that you have to choose the right mask. This one is the mask that you want to choose with a non-rebreather, or it's called non-rebreather, or sometimes it's called a reservoir mask. And in the OSCE, they're calling it a reservoir mask. And as you can see, it's got that chamber there where you can fill it with oxygen once it's connected to the oxygen. So that is the correct one. And also for that child, we need to make sure that it's the right size. So for that mannequin, it does work that size and fits nicely, but it could be a smaller one that was for a baby, or it could be a larger one that was for an adult. And for adults, the same, it should be the right size. But also we do get these, you might put a different mask like this one on. This is just a simple face mask, has no reservoir bag on it. It has no acorn either to change the flow rate. Some of them have a flow rate acorn. So they could give you that as well, but you want the high flow oxygen, which is through the reservoir mask. So you'd have to check that, and it probably will already be bagged, so you have to check the date and that the just mention that it's intact, the packaging. Before you fit the mask to the patient, you would need to attach it to oxygen, a point on the wall. So this is the oxygen point that you see in all hospitals, and it's slightly different from portable oxygen, because the point to attach it to is on the bottom bit. So you usually have to do that. If you're used to seeing it, maybe in a nursing home, if you're working in a nursing home, sometimes the point is here. So if it's not attached to the wall for any reason, like this one, remember it does go to the bottom. In the test centres, they won't have oxygen flowing through the walls, and also I'm very sure they do not have portable oxygen. So you are going to just assume that you're turning the oxygen on. So it shows you which way, that that way is opening it, the big end, and opening it completely would put it on the highest flow rate, which is 15 litres. So we would just assume that's 15 litres and verbalise it, because that's something the examiner might ask you. How do you know the correct flow rate? And you would say because the ball is now on 15 litres on the flowometer. And to make that reservoir bag inflate, you need to push the valve down with your finger. So that would be pushed down already. And then you could say to the examiner, can I assume that bag is completely inflated? And at that point, you would have already checked the patient's ID. And if not, you need to before you apply the oxygen. Even if you've already checked their ID, if you've gone away out of the room as such to pick up the equipment, you need to recheck it on return. If you go to the patient with the oxygen already with you, the oxygen mask already with you, you could do just one ID check when you come to the patient. But if in your scenario you're acting as if you went and came back, you need to check, and you need to gel your hands in between. So obviously you have to gel your hands, that is a critical. So you'd have to explain to the patient, I need you to sit up right in the bed, and I'm going to try to put this mask on your face. So I'm going to just check that the areas around the back of the head and the face are intact and there's no sores, and just make sure it's the right size. This one looks the right size. So I would put the elastic on, making sure that it's the right size. And if it was loose, sometimes it's loose, you have to tighten it. This one fits very nicely onto the patient. And then there's a little bit of metal that you could squeeze the nose. So you squeeze the nose band to make sure it's comfortable and it's fitting properly, so there's no leaks. So just ask the patient if it's comfortable as well, and make sure that that is not going to be just pulled off as soon as you leave the room. So that one's comfortable for you. And also just let the patient, and if it's a child, you're telling the carer or adult with them that I'm going to be rechecking the oxygen levels, and probably reasonable time frame is about 15 minutes. So I'll come back in about 15 minutes, rechecking the saturations until we reach a target of 94 to 98%, and then I'll be letting the doctor know, and I'll just be checking the pressure areas and the face for comfort, and also be administering mouth care to make sure that the mouth doesn't dry out too much. And you would leave the patient, but before you leave the bedside, you're going to sign and make sure you're filling in the chart correctly. You're going to sign, you're going to print your name, put the date for today and the time, and it says FR/D. So FR/D is flow rate and device, and this is one of the things we find when we're doing training that people do forget to fill in, or they might just write the flow rate, 15 litres per minute, but they don't write the device, which it says is an RM, reservoir mask, and you need to do that for a pass. So make sure you filled all that in, and as I mentioned, the examiner will only be able to prompt you so much. So once you've completed all your paperwork and you've gelled your hands and you seem to have finished the station, the examiner will ask you, are you happy that you have now completed the station? And only when you say yes, they will say stop the timer and say the station is now complete and it's over, and they'll make a note of the time that it finished, and then they will ask you to sit while they reset the station. So that's what to expect in this station of oxygen administration, and just take a note of those things, and I'm hoping that gave you a bit more clarity on what to expect on the day.